Medication Administration, Chapter 31. This is Part 5, Martha Olson from Iowa Lakes Community College. Our topical medications are for the eye. First of all, we want to avoid the cornea because it has many pain fibers and thus very sensitive to anything being applied to it. With eye medications or eye ointments, our first eye ointment is usually in OB to that newborn baby to prevent gonorrhea that causes blindness to that baby. We use many eye drops for the older adult that have cataract extraction or glaucoma. Those ophthalmic medications then can be administered by the nurse. Many of your older clients have problems with vision, hand tremors, difficulty grasping or manipulating containers, and so that would affect their ability to self-administer those medications. We want to make sure that we think about the systemic effect of those medications. On page 617, it talks about holding pressure to that nasolacrimal duct for 30 to 60 seconds to avoid that medication going systemic. The intraocular installation is a disc that's very similar to a contact lens. It can be left in up to 1 week for the medication to work into the conjunctival sac. Patients would require teaching for that. And also, as we look at intraocular discs, think about the patient that's unresponsive. We would always want to assess if they have contact lenses in and remove those for that patient. Our ear installation, ears are very sensitive to temperature, so we would want to make sure that the eardrops are at room temperature to prevent vertigo, any dizziness or nausea for that patient. The outer structure of the ear is not sterile, but anything put in the ear would have to be a sterile solution in case that eardrum is ruptured. If we do notice ear drainage, we want to make sure that we assess that to make sure what that is coming from. Never irrigate if we think there is a rupture of the eardrum and possible clear fluid. Forcing medications into an occluded ear canal creates pressure that could injure or rupture that eardrum. Our vaginal medications are usually administered by the patient because of the sensitive area and privacy. Vaginal medications can either be a suppository, foam, jelly, or cream, typically used to treat an infection. The discharge is often very foul smelling, and we want to follow aseptic technique, offer lots of perineal hygiene and support for that patient as they are going through that. Solid oval suppositories are individually wrapped in foil wrappers and usually stored in the refrigerator because they will melt at room or body temperature. After the vaginal suppository is inserted, the body temperature then would cause it to be absorbed and distributed as needed. As we look at the picture on page 598, it gives you the procedure for doing that, and the foam, jelly, or creams are administered as an applicator. Our medication inserted rectally is a suppository. The rounded end is inserted first to the anal canal to avoid trauma. We want to make sure that we lubricate that well with some kind of lubrication to prevent injury to that area. Rectal suppositories, again, are stored in the refrigerator until they're administered. They melt at room and body temperature, and that's how they work. Most of the time your rectal installation is a Dulcolax suppository for constipation, could be a Tylenol suppository for somebody that has a fever and they're not taking anything by mouth. And as we look on page 599 at the procedural guidelines, we know the patient must remain flat or on their side for at least 5 minutes to prevent the expulsion of a suppository. So a patient that is given a suppository to help them have a bowel movement, remember that suppository is applied in, not into a fecal mass, but between the fecal mass and the wall, so it stimulates that peristalsis to help that person. When we give inhalation medications, they can either be a spray, mist, or powder. We need to remember, are they rescue or maintenance? A rescue is just given to help them to prevent having problems, and a rescue med is often like your asthmatic that is having difficulty breathing. Patients who receive medications by inhalation frequently suffer more of our chronic respiratory like asthma, emphysema, or bronchitis. as we think about maintenance of these medications, that daily schedule, that good teaching of how to know when your device is almost empty and to order it so you don't run out, how to rinse and do good oral care to prevent getting thrush in the mouth. We want the person to be able to keep that down in their lungs as long as possible so it gets the full effect. The pressured meter dose, they have to have hand strength to be able to push the lever down in that. And then with the meter dose, the release depends on the patient taking a good deep breath in to pull that out of the inhaler device. Our dry powder is becoming something more frequently used. It's activated by the patient's breath, and when you activate the inhaler, it crushes the med. They put their mouth to it, they inhale, and the medication as a powder then is administered to them. Make sure that when we are doing patient teaching, we help them determine, again, is it about empty, and how can we go about getting that refilled before it indeed is empty. And then when we look at irrigation, I've done probably the most with eye and ear irrigation, not much to the vagina or the throat. We use aseptic technique. For the eye irrigation, you've probably seen the eye stations in the microbiology lab, in the ER. The patient would then just go to the sink. We take the red caps off, we turn the water on, they hold their head over that, and the flow of the water then comes into the eyes to irrigate them for a period of time. The person that I took care of that had an eye injury, they were a lower functioning person cleaning at the library, and they accidentally sprayed the cleaning solution into their eyes instead of on the glass. The ear irrigation I've done mostly in the clinic. Things to remember: you assess in the ear long before you start irrigating to make sure that that tympanic membrane is intact. You want to use tepid water. Too hot or too cold would be very uncomfortable and irritate. These are talked about on page 600. Irrigations are done to cleanse the area, to instill a medication. We irrigate in the ears, oftentimes to remove chunks of earwax that are keeping the person from hearing what they want to. And in the clinic, I had no training how to irrigate the ears. I just had another nurse show me, and then think about good principles with that. The other thing that we use with ear irrigation is to often put Colace, liquid Colace, a drop or two into the ear, have the patient lie so that runs into the ear to soften the earwax before we irrigate, and Colace then has the effect of kind of helping that earwax to be removed more easily. So our part 5 is done, and we will move on now to part 6, where we look at parenteral medication administration. Thank you.